nylon doesn't appear to impact limb occlusion pressure, neither does it appear to have any effect on muscle adaptations. In terms of prescribing BFR, protocols guiding restriction for resistance training in BFR, guideline A is outlined in this table. Sorry, I'm having a little difficulty. Next slide. Cuff. These are some of the cuffs or tools of occlusion. You have Kayatsu cuffs. There are elastic tourniquets. Rogue fitness band is another type. There is edge resistant bands, and this carries a manual pump. Resistance gluteal bands. You'll find quite a few of these items on Amazon. Of course, there's the Delphi BFR training system and cuff, which we'll hear more about later. Some persons have used gait belts. Some persons have used the blood pressure cuff. And of course, there are other occlusion tools or tourniquets that are being used and you will find on the market. Mr. Owens will tell you a little bit more about the cuffs and the systems. Okay, so indications for BFR: muscle atrophy and weakness, any condition requiring strengthening that we don't necessarily want to have great shearing forces on the joint. So you're looking at your patellofemoral syndrome. Post-surgically, ligament reconstruction repair. It can be used in the rehabilitation upper extremity injuries such as rotator cuff or labral tears. Lower limb condition, BFR can be used in the rehabilitation of tendon repairs, meniscal repairs, for muscle strains and repairs. Then, can that person mute their mic?
Please,
So,
mics,
muscle
everyone.
strains and repairs, ligament strains, chondral defects. BFR is being used pre and post game and is also included during training cycles for variability in training. Contraindications: DVT, if the person has impaired circulation, naturally if they have uncontrolled blood pressure. Infection, you want to watch out for acidosis, sickle cell anemia, if they have open wound or open tissue injuries. It's contraindicated in crush injuries if there is compromise of the peripheral vascular system, and for secondary or delayed procedures after immobilization. Next slide. When it comes on to research evidence, BFR can be used in rehabilitation to increase muscle strength, as we said, and to hypertrophy muscles. Lisandro et al. In 2008 did research on healthy young persons. So it can be used on the young as well as it can be used in the geriatric population. It is especially indicated, or research have shown, that where you have load compromised populations, BFR has been proven effective in helping with rehabilitation. BFR can be performed during isometric isotonic, high intensity, low intensity, and aerobic exercises. Several systematic and meta-analyses have been done comparing the use of BFR with these forms of exercise, and they have also looked on the effect on muscle function using exercise or these forms of exercises alone. BFR and low intensity exercise, they found greater muscle hypertrophy and strength changes. And with BFR and high intensity exercise, they found that persons had maximal strength gains. BFR training is said to bridge the gap between low and high intensity exercise interventions in rehabilitation and has been found to be an attractive and useful tool for load compromised individuals. In terms of prescribing BFR, guidelines have been presented by Brander et al. And we're looking at frequencies of 2 to 3 times per week, usually over a 3-week period. Load or intensity is low, so you're training at 20 to 40% of 1 RM. It's an 8-minute per exercise. The cuff is usually kept on throughout the entire program. And you're looking at 2 to 4 sets, 4 being optimal. The repetitions, very important. And they do a total routine, which is 75 reps. And it's broken down 30, 15, 15, 15. So first set, 30 reps, second rep, set, 15 reps, third set, 15 reps, fourth set, 15 reps, with 30-second rest in between sets. The pressure, 40 to 80% of the limb occlusion pressure. For the upper limb, 50%. For lower limb, 80% is recommended. Speed with concentric or eccentric exercise, 1 to 2 seconds. Duration is usually until there is fatigue or failure or the rep scheme is completed. When you're looking at passive BFR, so you're looking at those patients that are load compromised, or if they're immobilized or on a period of bed rest, then you're looking at same low intensity load, 20 to 40% of 1 RM. Restriction time, 8 minutes per exercise to allow reperfusion between exercises. We're now looking at 3 to 5 sets to failure. Rest period, 5 minutes between the sets, and the limb occlusion pressure, as you notice, will be higher, and you want to use between 70 to 100% limb occlusion pressure. This, of course, follows detailed assessment of the patient. So, first protocol was with resistant training, persons who are up and about. And this second protocol is when you apply passive BFR. Okay. Example of activities and modalities used with BFR include plyometric exercises. You can use BFR doing medical ball drills, endurance exercise such as walking or cycling. BFR can be used with stretching and mobility exercises, and it has also been looked at doing balance tasks And BFR can be used with neuromuscular electrical stimulation. And there are quite a number of studies out there that you can look up. References will follow. So, can we explore how safe is BFR? Concerns have been raised as to the effect on our vascular system and concerns over DVT due to the constriction of blood flow and, of course, the venous pooling issue. Multiple studies have been done looking at acute and chronic markers over 12-week periods usually, and they show no increased DVT markers. One such study was done by Nakajami in 2006, where he used a population of 12,000 participants, and the incidence of DVT and PE were like 0.05% or 0.008% respectively in terms of general risk markers. Only 2 studies, I believe, have been found. According to Patterson et al., they have found only 2 studies where they had some recorded incidents. In terms of muscle damage or rhabdomyolysis, and of course, this is a severe condition where trauma, indirect or direct, causes breakdown of muscle tissue, and it allows for the contents of the muscle, the breakdown, being released into the bloodstream. This is called exertional rhabdomyolysis, and this can lead, of course, to kidney failure and other life-threatening sequelae. Evidence doesn't currently suggest risk that is greater when compared to traditional exercise. And whatever risk there is, or the minimal risk there is reduced if the BFR protocol is being followed to the T. In terms of hemodynamic changes, they have noticed increased heart rate, increased BP, increased or decreased stroke volume, and they have raised concern related to how high a load or high intensity eccentric exercise affects these changes. Other issues related to BFR training has been associated with non-standard training programs, use of non-medical equipment, and if the person has other comorbidities. So, what can we do? It is recommended that we prescribe BFR correctly. Patient selection is important, so screening and assessment is very important before we get into BFR training. Accurately measuring the limb occlusion pressure, that's the gold standard in any BFR training that is being carried out. Use of repetitions as recommended, so our 75 repetitions, 4 sets, 30, 15, 15, 15 should be stuck to when you're doing BFR training. Use of appropriate device. So as I said before, there are many devices out there and different ones offer different, just like when you're choosing an exercise bike, there are many different mechanisms and different operation systems, but it's recommended that you get trained, whatever your choice is, if it's an occlusion system, if was any one of the other systems that I noted, Kayatsu training, it's important that you're trained to use the BFR training system and the appropriate devices. Of course, correct implementation is also important. So why is it significant? As we said before, BFR training is one mode of utilizing low intensity exercise or combining with low intensity exercise, minimizing shear forces on the joint, to bring about muscle adaptations in rehabilitation. So for your strength gain, hypertrophy, positive effect on your vascular system, BFR is the way to go, and it has been proven to bridge the gap, as we said, between low intensity exercise and high intensity exercise. It's been around for over 50 years, and it's definitely a tool that we can use in our toolbox in sports medicine rehabilitation. So that concludes my presentation. Thank you for listening. And as the evening goes by, we'll definitely learn more about the system, BFR training, and the application. Thank you.
All right, thank you very much, Piran. Very interesting topic and introduction. We'll have about 10 minutes for question and answers now. Are there any questions? If you have a question, you can raise your hand and you'll be acknowledged, and then Piran will attempt to answer. Any questions?
All right, Doc, I have one question. Good afternoon, everyone.
Okay. Go ahead there.
Yes, yes, Piran, I had a question. I noticed with the protocol for the reps, it was
Yes.
30 reps, then 15, 15, 15, something like that?
Yes.
All right, what's the reason for the difference in the reps? Was there a difference in the occlusion pressure with each set? Is it, I say 30 reps?
No, remember I mentioned that the cuff stays on. Even during the rest period, the cuff stays on during that time. And this protocol was first developed by Dr. Sato, as I said. And with continued research, they have found that it works. So that is the protocol that is recommended.
Well, I guess I'm wondering, so have they tried 15 reps for all sets or 30, 30, 30? I'm wondering what the difference, by the 30 first and then go down to 15. Or have they tried, have they tried other repetition schemes? I guess
they have, because you know that the protocol changes for even aerobic exercise.
Right, yes.
It's to voluntary fatigue or fatigue of the muscle. I guess the cough and the occlusion is pretty intense. So even during the exercise training, it's a bit uncomfortable because of the occlusion pressure.
Right.
So I surmise that it has to do with that. And Mr. Owens will probably comment further on in the webinar as to why the 30, 15, 15.
Okay.
But it has to do with the level of discomfort that persons experience throughout the training session.
I can comment now, Piran, if you want. This is Johnny.
Okay, Johnny, please.
Because I don't have it in my talk. That's a good question. And you know,
Yes.
the quick answer is there's nothing set in stone with this, but the general hypothesis with the first set being such high volume is it's typically easier to do that first set because even though we're restricting the arterial flow, you still have enough oxygen perfused within the muscle that you do a high volume first set to basically make Krebs cycles stop or slow down. So you do that first 30, it feels like low load and it's basic because you still have oxygen. And then you just really can't tolerate that high of a volume once you move into the anaerobic fast twitch, those final 3 sets. So it seems to work. We put out a position stand paper with researchers around the world and kind of reviewed all the papers, and 30, 15, 15, 15 works, but other ways work as well. And a couple of our trials that we're doing now, we really like this 30, 15, 15 in that last set, just go to failure and go till you can't go anymore. So we might see some change in that, but this way does seem to work.
All right.
Thank you both.
All right, we have a question from Orlando.
Yeah, good afternoon, everybody.
Good afternoon, Marlando.
All right, so my question, it stemmed from when you were talking about the advantages of BFR, and you were mentioning about the fact that we don't have to use the heavy weights to load the joint. So it allows us that advantage of using the low weight with high reps. And then I thought about the loading in terms of like a closed chain versus open chain exercises. And then I wondered to myself if you have any information as with BFR with open chain versus closed chain exercises, as in have you found better results with the open chain exercises or not?
Now, Johnny is going to get into the research into the 21st century, so he'll give a lot of examples there in terms of research. But there's research being done. I know knee osteoarthritis, patellofemoral syndrome, ACL rehabilitation. So there are a lot of researches out there with results available. But Mr. Owens will get into that when he gives his presentation. He'll look at all the research and give you examples. So yes, we're actually minimizing the shearing forces on the joint with BFR and low intensity exercise.
Okay.
So stay tuned, Marlando.
I don't have a specific slide on open versus closed chain, but if you want, I can also give my thoughts there. I don't want to take over your question and answer time though. So.
Go ahead, you're the authority. I have no issues there.
So it is nice doing open chain because we can really isolate a specific muscle group. And so say post-op ACL, if we're a little bit worried about potential load and pain at the joint or some shear with the ligament, just going after something like a long arc quad, you can really, really isolate these muscles at a very low load and decrease the stress. We can't say probably that there's a real difference from what we see in the literature right now between open and closed chain. One thing with closed chain that we are seeing though is that if you are doing something like say a squat or a leg press, the muscles below the cuff really fatigue pretty rapidly. And so we're seeing some adaptation above the cuff. So those multi-joint kind of closed chain exercises might be our way to go and get some proximal changes at the hip and at the shoulder as well. There's been some EMG data. If you do bench press with the cuffs on at low load, you have higher EMG at your pec versus doing the same low load with it off. And we've also seen some positive changes at the hip. So I think that would be the main reason I really think about closed versus open chain right now.
Okay.
Okay. All right. Thank you.
Question. Demoy?
Yes, sorry. Earlier, I was wondering if I heard properly or if I heard the wrong thing. Is it that we said that with blood flow restriction, there is low venous return or no venous return? Wasn't quite sure.
Yes, you're stopping arterial blood flow into the limb, and you're partially occluding the you're restricting the arterial and you're completely restricting venous return. So partial arterial blood flow to the muscle, but you're completely restricting venous flow.
We're saying the treatment time is 8 minutes.
Roughly.
All right, so it's
8
8 minutes.
in one and I think 5. 8 in one and 5 in the other.
Okay, okay, that must be difficult. All right, thank you very much.
That's why the set or the repetitions as it. And it's to voluntary failure.
Right.
Or to voluntary failure.
Okay, all right, clear.
Okay.
All right, thank you for those questions, and thank you, Piran, for that enlightening presentation. Could see that a lot of research went into it. At this time, we are going to give our sponsors, Qualcare Limited, a chance to update us on some of their products. The person presenting will be Director of Marketing, Mr. David Thompson. And it's a pleasure to have Mr. Thompson with us this afternoon. So at this point, I'll hand over to him.
Meeting, I can remember Dr. Joan Rattray many years ago when we launched a product from Ciba-Geigy. It was at that time we were very active with the Jamaica Sports Medicine Association. So I'm indeed very happy again to be involved. Actually, times have changed. If somebody had told me maybe a year ago that speaking about a virus or about a pandemic in a sports medicine meeting, I would say, wow, that might not be possible. But we have all seen over the past year that things have changed. And I decided that even though we at Qualcare, we have a lot of products for sports medicine that includes non-steroidal anti-inflammatory drugs, both systemic and topicals, I thought that it was more appropriate, since it's a sports medicine meeting and you doctors and specialists will be in contact constantly with the coaches. And this is all about sports, practicing, training and all of that. And certainly COVID is an important factor to consider. So I asked our supplier, Jameson Wellness Corporation, Jameson Vitamin Canada, if they would allow us to present their immunity support products in this meeting, and they agreed. Actually, the presentation was prepared by them because they are very strict about their message to the public, which includes doctors, specialists, the end user, it doesn't matter. So I would just like to, if I can get this thing to work, is my slide being shared? Is my slide being shared?
Yes, yes, David, we can see it.
Okay, good.
Go ahead.
Yeah, just quickly, you know, this will be very short, no, less than 10 minutes, certainly, because we all know what vitamins do, and whether it's vitamin C or vitamin D, right? But nevertheless, my task is to emphasize the company that supplies the vitamin, which is Jameson out of Canada. And it is very important for us in marketing to establish credibility. And we establish credibility not only by the quality of the products that we produce, but by the fact that we have been around for a very long time. Jameson will be 100 years old next year. So it is a company that has stood, or withstood rather, the test of time. Their corporate offices in Toronto, Mississauga, Canada, and they also have an office in Shanghai, China. You know, very large manufacturing facilities and all of that. Why is this important? Because there are so many choices of vitamins in Jamaica and in Latin America in general. And we believe that it is very important for us as Qualcare, the distributor, to explain to the doctors that not all vitamins are the same. For example, we have had the task of explaining to our end users and sometimes even the pharmacists that, yes, the vitamin C, after a while in the bottles that it comes, it becomes a little bit dark in color. And the reason for that is because it is a natural vitamin. It is not a synthetic vitamin. It is not ascorbic acid out of some lab. Just like how an orange or a mango, when it is cut, you give it about a couple of seconds, maybe a minute, it starts to become dark. That's the same thing, oxidation, you know, oxidizing many of these organic substances, whether it is flavonoids, xanthoids, or whatever. Good. So that's only natural. But we have the assurance that regardless of the color of our vitamin C, it is perfectly good and it is perfectly effective. Now, Jameson is a company that operates in 50 countries around the world with more than 700 products, right? It has the approval of the FDA, Health Canada, and Australia, and you name it. So it is a company that has all the backing of the regulatory authorities in various countries. It has a very long established protocol that they call 360 Pure. Quite frankly, 360 Pure has to do with ensuring at a manufacturing level, at a logistics level, that everything that you use is pure. They are able to track even the raw material that they get back to the source where it came from. Just in case there are any problems, they are able to backtrack to even the supplier in wherever that they got the raw material. So that is something we believe that really emphasizes the care that is put in manufacturing their immunity products. Vitamin C, as we all know, you know, I learned many years ago when I heard about these pyretes in scurvy and the importance of it. We all know that vitamin C is water soluble, so it is not stored in the body, and it is excreted very easily, urination and so on. However, many people say that they do not need to take vitamin C because they are drinking a lot of stuff and so on. But, you know, we should also realize that sometimes these vitamin C that they think that they are getting it from natural sources, but what they are doing is that they are boiling it. And, you know, this very often destroys the vitamin C. So they're actually getting very little, if any at all. So speaking about vitamin C, you know, without going through too much what it does, because it is quite clear what it does. It is very important for the immunological system. But I'll just remark to you that what happened in 2020 is an indication of how important people realize that vitamin C is. In 1 day and a half, we sold at Qualcare more vitamin C than we have sold in a year. Yeah. So that is, I believe, something that shows how important vitamin C is to the people now that we are in the time of the pandemic. And of course, who are more exposed to the virus than the sportsmen, they have got to go to training, they have got to go to competition, you know. So we thought that, you know, it is very important for them to have knowledge of the vitamin C's that are available and the good ones, the ones that are actually natural and are actually potent enough to protect them. Okay, so just going down, I'll just speak briefly about vitamin D, which quite frankly, I was under the impression that dark-skinned people didn't have to worry about vitamin C, about vitamin D, you know. I was recently schooled on that. I think it was Dr. Ratridge, my old friend, who said that, no, Tomo, That was first time, you know, because now people are spending a lot of times indoor in air conditioning. They're covered up when they go when they're outside, and they're not getting the opportunity to produce vitamin C in the skin, like it was when I was a child. We used to play football, even sometimes without wearing a shirt, you know. And but things have changed drastically now. So it is very important for vitamin D to be considered as a supplement in this pandemic time and for the natural health of the person, whether they are dark-skinned or light-skinned. My favorite topic about this immunity product is zinc. Now, I'm an old natural scientist, as I like to tell people. I did special chemistry at the University of the West Indies many years ago. I know I've forgotten 99% of it. But what I do know is that zinc, right, is a metal that is quite forms what we call metal organic compounds with whatever it is. You know, these viruses or bacteria, they all have some sulfur hydryl group, the SH group or NH group or OH group, right? So there's always these chances of them forming covalent bonds with the zinc metal. Now, there are many studies which I could ask Jameson to send about the use of zinc in the immune system and how it actually captures the virus or the bacteria for that matter, or even the fungus. Zinc, of course, it is said that should not be exceeded 50 milligrams per day. However, I'd like to introduce you to this favorite product of mine, and this I believe will be very important in sports medicine, especially now I understand that schoolboy football will be kicking off sometime soon. This is the Zinc Lozenges. It has vitamin C, it has echinacea, it has some vitamin D and so on, but most important, it has zinc in it. And it is said that if you get to control the virus while it's in the mouth or the throat, it avoids a lot of problems, you know, because certainly you will not get it going down into the lungs. This zinc lozenges is available in all pharmacies in Jamaica, right? It is quite inexpensive. Can't remember now the price. There are so many products I'm not able to remember the price of it. But it has 10 mgs, I believe, of zinc, and it can be used 3 to 4 times per day. So with that, you know, if a person is exposed as they are in sports, practicing, being in close contact with their competitors, it is also, I believe, something that is worthwhile considering to the coaches and the players themselves to attack the virus while it's still in their mouth and before it becomes more complicated. What I'd like to do to end all of this, because, you know, this is a commercial break as far as I'm seeing it. I am just a marketing salesman, right? I would like to offer one of these products, one of each of these products, I should say, to everybody who is involved in the webinar. I've already had the agreement with Jameson. So all I'm gonna need is the names or the addresses or somebody who could disperse these. I don't want to call them samples because these are actually sales goods, so that you can see for yourself these products, the quality of it, and maybe you can recommend it or try it yourself. So I do not know if it is possible to get the list of participants. I'm seeing that there are 58 persons now. I was hoping that it would be more than that it would be 158, but nevertheless, you know, we will send one of each of these products to everybody from Qualcare Limited. So with that, that is it about Jameson and its immunity support products.
Dr.
Right. Yeah, but-
Hanson, you can collect.
Pardon me?
You can collect the samples.
I can
Well-
send it to Dr. Hanson.
You can, or Joan would have the list of people too.
Right. It might be easier to send it to you, Joan, because since you're so near to
Yes,
our
a call
qual
care.
care.
Yeah.
Right. I
Sure.
think that's the easiest thing for us to do. And then you could, you could send it to the appropriate persons, eh?
I will do that. Maybe by the end of our session, the numbers might go up.
It doesn't matter. It doesn't matter.
We might
Or
have
500, it doesn't matter.
All right.
We have that commitment.
All right. No, fine. I'm just letting you know that it may not just be the 58. We probably will have more people join.
YouTube.
On,
Yeah,
we have to
yeah.
check the YouTube link as well.
YouTube link.
Thank you very much. Great.
Okay, good.
And the lozenges they taste good.
Oh, yes.
And the vitamin C gummies are really lovely.
Yeah. I should have.
And I can, huh?
I should have said that the lozenges are the only ones that I know about in Jamaica that actually has zinc in it, So I know the rest of them have all sorts of other, maybe something to, like some lidocaine type of stuff to reduce pain or whatever. But this one
Do you
actually
have
has.
the Jameson product that does hair, nails? It's called Immunity Hair, Nails.
Yes,
Hair and
actually
nails.
we do.
That is awesome. I mean, really promotes hardening of the nails and hair growth.
All right, so Mr. Thompson, you have some models there who are willing to volunteer to model your products, the benefits of your products.
Oh, yes.
Just one question. Just one question for you.
Yes.
In sports medicine, one of our concerns is supplements and their purity.
Right.
Because there have been instances where elite athletes have been on supplements and then they test positive for a banned substance.
Right.
And they trace it back to the manufacturer's warehouse or production line and I saw where you had was it China or Hong Kong?
Hong Kong, yeah.
As one of the sites where your products are manufactured. What are the guarantees of the purity of your products? I saw where you said they were FDA approved and you had a number of certificates.
Right. Yeah, that is a reality now in the pharmaceutical industry. Is in that it doesn't matter where, it matters the company, and the company has its own standards. So it doesn't matter whether it is produced in China or it is produced in Jamaica. The standard of operating, the quality control, everything has to be exactly by the book of the manufacturing company or the company responsible. Because, for example, if you look at the many companies now are manufacturing in India, China, Bangladesh, Vietnam, you name it, right? But it is according to their standard,
All right, well, thank you very much. Very good presentation. I see good comments on the chat about it, endorsing your products. Thank you very much for sponsoring us and participating in this session.
Right, and we look forward to participating in future sessions now if we are advised, okay?
All right, we'll bear that in mind. Thank you for the offer.
All right, thank you very much.
Right along.
Right, I've got to go now, because some people might realize I'm not in Jamaica and I'm in the DR, so I'm 1 hour ahead of you. So.
All right. Okay. Thanks for making the time to be with us.
Okay, my pleasure. Bye-bye.
All right, moving right along, we come to the main event, so to speak. Next on the agenda is a presentation by Johnny Owens, our specially invited guest speaker. And to do the introduction, we're going to ask Tony and Grant to do the honors. Tony.
Good afternoon, everyone. The gentleman I have the pleasure of introducing this afternoon wears many hats and is indeed talented. He is the CEO and Director of Clinical Education for Owens Recovery Science, a corporation recognized in the INC 500. He manages a research portfolio for over 40 clinical trials being conducted worldwide, primarily studying the effects of blood flow restriction rehabilitation in clinical populations. He is also the former Chief of Human Performance Optimization at the Center for the Intrepid in San Antonio Military Medical Center and continues to serve as a consultant and clinical researcher at said facility. He completed an undergraduate studies, in biology at the University of Texas in Austin and earned his master's in physical therapy at the University of Texas Medical Center. He serves as a medical consultant for teams in the NFL, NBA, Major League Baseball, NHL, as well as collegiate sports. He is involved in numerous clinical trials involving regenerative medicine, sports medicine, blood flow restriction, and high energy trauma. This gentleman has been published extensively in peer-reviewed literature, regularly speaks at national and international levels, and his work has been featured on 60 Minutes, Time Magazine, NPR, Discovery Channel, as well as ESPN. Ladies and gentlemen, I give you Mr. Johnny Owens.
Thanks for that great introduction.
Welcome.
Thanks for having me. I wish I was down in Jamaica. It's probably much more fun than being in South Texas right now.
Come on down.
I've been there. I love it. So everyone see my screen?
Yeah.
Okay.
Yes,
So-
good.
Yes, we can.
I was asked to not only kind of talk a bit about blood flow restriction, but talk a little bit about the company I'm with, Owens Recovery Science, as well as the system that we use for blood flow restriction. So I'm going to touch on that a little bit, and then kind of where we're headed with this and what we're seeing in the States right now, because it's really taken off quite a bit. So who is Owens Recovery Science? Where we do three things. One of them is education. So we do blood flow restriction certification courses here in the States, in Europe, in Australia, and Asia. We haven't done one down in your neck of the woods yet. We also try and put out content and education. So we have blogs that we put out and podcasts. And so Pierre Ann just asked me to kind of put out our upcoming courses. So if you guys are interested and you want to learn more about BFR and get certified, we do have one in Puerto Rico coming up next year, as well as in Florida. If you like this topic, we try and put out a blog every few weeks. And so if you go to our website, owensrecoveryscience.com, there's a lot of blogs that go in from everything for how to use potentially BFR for performance to, how to use it for clinical applications. If you guys just love my voice, you can listen to it all the time. We have a bunch of podcasts here. And we try and bring in BFR research experts and my colleagues from around the world. We've had MLB and the US Olympic folks on, NFL, NBA, et cetera, of how they're doing it in pro sports and a lot of clinical things there. So we try to put out, this is such a new and burgeoning kind of topic that we try and really put out as much content as possible. The APTA, so our governing body over here in the States, asked us to build a independent study course on what blood flow restriction is. So we did that a couple of years ago. And so if you want to get an actual course through our APTA website, we made a whole pretty large course on what it is. And now we are starting to teach it in the States in school. So we have a partnership and we teach at University of Southern California. We teach at Army Baylor as well, and now many other schools are starting to come on board. So now we're not only seeing kind of an advanced education component, but the young graduates that are going to be coming out of school over here, we're hoping that they're trained in blood flow restriction. And there's a couple of key points when we worked with the APTA on this. One is just to at least understand what blood flow restriction is and the applications of it. But there's a second component, and that's tourniquet use and safety. And so most of us are not taught how to use a tourniquet in school. And so from a liability standpoint, one of our key concerns is that everyone understands applications of a tourniquet, what to look for from a safety profile, and what to look for once you're done with it for any concerns. It's really taken off over here in the States right now. So we've trained over 8,500 people. We've pretty much trained every professional team in all the leagues. We're with NASA now, Apple, with the Premier Leagues in Europe, and the US Olympic teams over here. And probably the biggest spread of this has been through the Department of Defense. Probably the thing I'm most proud of, as was mentioned in my intro, is we really try and put our money where our mouth is. So we have clinical trials going on all over the world that we're either directly involved with, we've received funding for, we're working as a consultant or as associate investigators. And so I have $6 million myself in funding just from the DoD. We got another $1.4 million this year to study BFR long-term effects in ACLs. And the majority of our studies are orthopedic trials, but now we do have 3 pediatric trials going on. We have a diabetes trial going on in Germany. We just finished a Parkinson's trial. We have an MS trial going on in Colorado. So we're really moving on beyond orthopedics to maybe the groups that might benefit the most from it, we think, or some of the elderly kind of comorbid type of diseases. Just as I mentioned, the Department of Defense is probably the biggest user of this in the States. And so that's kind of where my story with blood flow restriction started. So I'm in San Antonio, Texas, and we're called Military City, USA. So we have the majority of the military bases, and what we have the largest of is the military medical facilities. So we have the only level 1 trauma center and the largest military hospital in the world. And so I was there during the wars as Chief of Human Performance Optimization at a place called the Center for the Intrepid, which is kind of the DoD shining star for rehab and research. Not only do we have our large hospital and the rehab facility, but we also have the Institute of Surgical Research. And so that's where all of our animal labs are, as well as our physiologists and scientists. And so we were really trying to find ways to help with combat casualties. And our burden of war was that we were seeing a whole lot of really, really bad injuries that would have killed service members in prior conflicts, but they were living just because our ability to take care of them in theater was just so much more robust. So the fatality rates were really the lowest we've ever seen for any modern day conflicts, but the injuries were worse and worse and worse. So we were overburdened on the rehab and orthopedic side of the house of trying to get these people back to higher function. So that's where my role as Chief of Human Performance was with the Department of Defense. And so no matter what you hear during the wars, this big blue area in the pie charts is the extremity injuries. And so the DoD is very good at dealing with extremity injuries more than anything else. And so that was really our biggest burden. And so this was kind of our hallmark injury. The lower leg was the most injured long bone of the body, the tibia. And so this is a typical IED type 3 open tibia. This is the typical kind of progress. So a couple of years later, we were able to salvage that limb. But that limb ended up being amputated on down the line because it wasn't functional. So the ankle barely moved. He'd lost a large amount of muscle, so he didn't have any more calf power. And so we were saving a bunch of limbs, and then they were coming back a year or 2 years later and asking us to cut them off. So we developed this prosthetic that we actually build around your leg. So you keep your leg and you put this device on. And what we were able to see is whenever we did that, so this is a fused ankle here. And fused ankles shouldn't be able to run because their calf doesn't give them any more power. All he has is midfoot power. But this device has a blade in the back that actually gives them the ability to land and push off. And so this is a fused ankle running. And this is something that they typically don't do. So the DoD, and this was one of my programs, put a ton of money into this. They patented the device. We have 14 papers that come out that we've done everything from reduce amputations to increase deployment rates if you use this device after an injury. The problem was, if you look at this chart over here, that you had to have twice as much strength. So this red line is a below knee amputee's quad strength. This green and blue is how much quad strength you had to have for this device to work. So if we cut your leg off, you didn't have to have as much quad. If we kept your leg, you had to be really strong in your quad. And most of these blast trauma folks weren't able to handle load. And so we looked at blood flow restriction. And as Pierre-Anne mentioned, we didn't invent it. We just really championed it. It's been around for a while. And I'll say one thing on the Sato thing, he did quite a bit of work, but we found papers of its application. The earliest one we found was in 1937 in JAMA. So it's been around much, much longer than I think a lot of people even know. But this was the first cohort that we started studying the safety profile and the application on, just to get it on these individuals, and they could do a low load and we could increase their thigh strength so that this device would work for them and that they could keep their limb. We chose 7 special forces patients to study at first. And so our initial blood flow restriction publication many years ago was looking at this application in limb salvage patients who had plateaued. We couldn't get any of their strength back. And all 7 of those individuals made significant gains in their strength if we did blood flow restriction for only a 2-week period. Sorry, my thing keeps stalling out. Oops. And then we started looking at other applications beyond just the limb salvage piece. And so what we found out is that if you lost some chunks of muscle in the battlefield, just a 10% loss of muscle really made it where you had severe outcomes as far as function, and about 90% plus would go on to be disabled and kicked out of the military just for some loss of muscle. And so what we found out is that in an animal model, if you took out a little bit of muscle, that if you force those animals to start to basically run and almost sprint at week 1 and get up to several miles by a few weeks after that, this really high anabolic stimulus, high intensity exercise, that we actually were able to make the muscle regenerate. And so if you look at this here, B and D is the muscle. If you just had a muscle injury and you were immobilized and did nothing, so this is the animals that weren't put on a treadmill. This green is called laminin. You want to see a real tight structure there. It's really spread out. And all this red is scar. And so the muscle just scarred down. But if we force those animals to run very early and really get that high intensity kind of exercise, the muscle actually truly regenerated. And so this was our next cohort that we really started looking at this in the Department of Defense over here is, could we use this? And this is our early research tourniquets here. Could we put these tourniquets on in these people who'd lost chunks of muscle and restore their strength, basically giving them a heavy stimulus, heavy exercise stimulus at a very low load. And so this is still a very promising field that we can make muscle recover. And what we have to think about is this goes beyond just, you're saying, well, my people don't have, pieces of muscle that were lost from blast injury. But some really interesting work came out a couple of years ago in Journal of Bone and Joint Surgery, JBJS, that if you look at someone's ACL, their quad after they tear their ACL, and on a biopsy, it's full of fibrosis after you tear your ACL compared to the other quad, and its muscle stem cell pool is significantly down. So just doing something like tearing an ACL, we see that this muscle wants to go to fibrosis. And then if you rebiopsy it when they were cleared to return to play, you still see a really stiff and scarred down muscle and a lower level of the muscle stem cell, which are the things that really promote long-term growth. And so these orthopedic type injuries, we're trying to see now, can we give some sort of high stimulus through low load blood flow restriction that can maybe reverse that process, similar to what I just showed in this animal model here. Lastly, in the Department of Defense, we went on to looking at the general orthopedic injuries, and that's kind of where it proliferated over here with the military in the States, because we have a lot more of these individuals. We had about 1,000 traumatic amputations during the wars, but we had 50,000 ACLs. And so we've really seen the promise, and that's why the DoD is funding so many trials looking at this right now in America. It progressed out of the military pretty quickly into the professional sports world. And so we did a story with ESPN in 2014 about this new technique we were seeing that was showing really promising results. Right after that, the #1 draft pick, Jadeveon Clowney, went down with what they thought was a career-ending injury. We helped the Houston Texans learn how to do blood flow restriction and get the units to do it. Jadeveon Clowney did fantastic, and he was the first documented professional player that we know of that actually did blood flow restriction. Now it has progressed. Now it's progressed that in the States, if you are in any professional league with any professional team, if you get an injury, that the professional workers' comp will buy one of these Delphi systems for you, for the player to use. So we already have moved on to pretty much every pro player. If it's a BFR appropriate injury, we'll get a BFR system to do their rehab. It doesn't matter how great it is if you're not able to practice it. And so just to kind of let you know where we are right now with scope of practice, is it okay for therapists in the States to do blood flow restriction? We have 3 scopes of practice that we look at here. One's your professional. So that's what are you taught in school? Is this basically in your general scope of what we say therapists do? You have jurisdictional. In America, every state has a different practice act. So we have to make sure that it meets the legal scope. And then you have a personal scope of practice, which is basically that you have done what you should do to make sure you're educated and to do something you might have not been taught in school. The APTA has put out a statement on their website that says blood flow restriction meets the professional scope of practice after they did Practice Act reviews. However, they said we still have to make sure we have the personal scope as well as the jurisdictional scope. And then also over here, the Athletic Training Association has put out a similar statement as well. We have one state in America that has taken away blood flow restriction in 2019 because they said it wasn't part of the Practice Act, and therapists should not be able to practice that. But we were able to work with North Carolina, which was the state that did it, to show them that it does look like it's within our Practice Act. We teach it in education. It's being done throughout the United States, and we have continuing education programs for people to get their personal scope. And so they reverse that practice. So now in America, it's practiced in every state, and we don't really see that we're going to have any issues with Practice Acts here. They did say that it is incumbent on the licensee to make sure they obtain the proper training to learn how to do this if they're not taught it in school. And then that's the last piece. That's where we stand now with this. Just the personal scope. Make sure that you understand how to do this. You don't just start something willy-nilly just because you read a single paper or saw a YouTube video. The other regulatory thing that we watch over here in the States is the FDA. Because tourniquets are considered medical devices in the States, that if there is any adverse events, they typically should be reported to the FDA. And so if we look last year, this is the adverse events page that the FDA has. And for 2020, this is the adverse events that were reported to the FDA. And so some of it is just the unit didn't work, or I couldn't get the unit to deflate, to I have felt like I had nerve damage or lost sensation in my limb after using this. So we're, from a regulatory side, really watching this. And this is where I think we have to be careful that we're just not cutting people's blood flow off with anything out there. And so what is the concern with tourniquet? Pierre Ann went into some of the safety of BFR. General tourniquet concerns, if you talk to the experts out there, one of the things that they worry about is a compression injury. So one of the biggest risk factors from using a tourniquet is actual compression on the nerve. And so a patient gets done with a tourniquet and they have some sort of nerve injury, either from a sensory side or from the motor side. And it's usually from a pressure gradient. And so if you go into surgery in the hospital, they're going to use wide tapered tourniquets like this. And they have a lot of surface area and they have real low pressure gradients. But the more narrow your tourniquets get, or if you've got a tourniquet that someone doesn't know how to build a right tourniquet, it doesn't have the elastomers on the sides here, you get these sharp kind of pressure gradients. And those actually can really put pressure on a nerve especially when you're moving the limb. And this is where you'll see demyelination of the limb. And so this is a tourniquet-induced nerve injury from a pressure gradient that went through it, and it demyelinated the limb here. And so this tourniquet review safety paper put out basically that higher tourniquet pressures and higher pressure gradients beneath tourniquet cuffs are associated with higher nerve-related injuries, that we should be measuring limb occlusion pressures. If we use tourniquets on people, basically personalize the pressure to each individual. We base the pressure based on how much pressure it takes to make the arterial flow stop. That's different from everyone. There's a lot of factors that change that, and that we should be using pneumatic, wider, and contoured tourniquet cuffs to reduce these pressure gradients. And that's where we just want to, buyer beware. There's things like this out here. So these are mattress straps, and then someone's flipped them around and calls them BFR bands on Amazon. That is a nightmare. Do not ever go down this road here. And if you do, I wouldn't do it on a patient for sure. And if you do, buy the mattress straps, because they were half the price. So they jacked up the price just by calling it BFR bands. I'm joking, don't use them at all. But there's a lot of stuff out there. It's not a very regulated field just yet from the medical device side, but it might be here soon with some of these potential injuries we're seeing. So just evolutions of tourniquets here. Tourniquets were basically considered fairly dangerous initially and through up to around the 1980s. And so they were class 2 medical devices, which is a higher risk medical device classification. In 1980, Dr. McEwen and Delphi invented the modern day microprocess tourniquets. It's what everyone uses in surgeries now. And whenever that was invented, the injuries, nerve injuries and other associated injuries with tourniquets became so low when you use one of those devices, the FDA reclassified it as a class 1 device. And that's the same classification as a toothbrush. So it's very safe now if you use the right device. And these microprocess devices are really, I think, the safest we can use. The unfortunate thing with them is they're expensive. Other thing on safety here, tourniquets go here. I'm not going to go into all the applications and safety, but this is a real basic, easy one here for you to understand that the tourniquet should go on the highest portion of the thigh or the arm. They're made to have a muscle mass and soft tissue under them to take down the potential for nerve damage. So if you're practicing it or you see someone practicing it and they have a tourniquet down below the knee because they're maybe working on an ankle problem with the person, tell them to stop it and get it up as high as they can, because the tourniquet can take out the fibular nerve very easily. And that patient would much rather have their ankle injury than a foot drop. So just keep those tourniquets as high as you possibly can. Okay, moving on from that, skeletal muscle. Oops, sorry, I missed this slide here. So Pierre-Anne wanted me to just mention the Delphi system that we use. So over here in the States and Europe, Australia, et cetera, like I mentioned, we use these Delphi systems. I think they really are the gold standard for blood flow restriction units right now. They have pre-programmed protocols in them. They will deflate after a certain amount of time. So if you're not watching your patients, it has a safety deflation. Probably one of the best things about it is it has limb occlusion pressure technology. So you just press this button and it basically does a Doppler reading for you. They have the patent on that. So they're really the only ones out there that have that. Counts your sets and reps, and it has a microprocessor in it. So it moves the cuff to make sure it is decreasing those pressure gradients. Okay, moving on from that. So I'm going to kind of get back into blood flow restriction and some of the physiology here. So skeletal muscle is plastic. And what that means is muscle will either grow if you give it a stimulus to make it grow. It can do nothing if you're just kind of in a normal fasted or a normal fed state and just moving around. Or if you get into disuse, your skeletal muscle will go away. So it changes based on what stimulus you give it. And it really starts to go away quickly, and it goes away at a very predictable rate. So if you're in a disuse type of period, so post-surgery, or you're on crutches, you basically are going to lose about 1% of muscle loss a day during the initial 5 days, and it kind of progresses and waxes and wanes over the next 10 to 14 days. And I think any of us who've worked with post-surgical patients have seen this patient. This is about 10 to 14 days post-op ACL, come in, you take the brace off, and their quad's basically almost completely gone. They've got a femur for a muscle now. And so this is called anabolic resistance. And this is the disuse timeline here. So day one, if you put someone in a cast and look at changes in their muscle, really nothing happens. But already by day two, if you got an MRI of someone who was using crutches and in a cast, they've already lost size of their thigh muscle, mostly their quad. By day three, muscle protein synthesis starts to go down. And so if muscle protein synthesis goes down, your net protein balance equation starts to get negative. And so if you ever see muscle synthesis going down, then you're potentially going to start losing muscle because that equation gets negative. And by day three, it's already going down by 30%. Now, day five, you're really seeing this increase in muscle protein breakdown. So you're not synthesizing as much, you're breaking down more. So you're really starting to dump muscle. If you look at someone who is basically in bed rest for 1 week, they lose about 3 pounds of muscle throughout their entire body. And to put that into perspective, it would take about 12 to 16 weeks of high intensity resistance training just to try and get that much muscle back. And then day 14, it's all gone to hell in a handbasket. So your muscle protein synthesis is down 30%. You've typically lost about 10% of the size of your quad, and you've lost about 25% of your quad strength in those first 2 weeks. So what we really want to look at with blood flow restriction is a way that we can get it on people and potentially get it on early to try and slow down these kind of bad things that happen here. So there's 3 ways that we really do it. One is passive. And so as Pierre-Anne spoke on earlier, passive is basically you're letting the tourniquet do the work. You're putting the tourniquet on, the patient's maybe a post-op or they're in a cast, they can't really do anything. You're putting the tourniquet on them and it is going through different inflation and deflation cycles. trying to just slow down the atrophy train. So this passive application, we don't see hypertrophy or increased strength, but we typically see less loss of muscle and less loss of strength. You'll hear this called also ischemic preconditioning or remote ischemic preconditioning or cell swelling. In this phase, we really like to combine things like electrical stimulation, isometrics, or very, very low load exercises with it to try and slow down the loss of muscle. The aerobic exercise kind of lives in the middle of passive and doing resistance training with it. And this is able to get maybe a mild increase in muscle strength and muscle size. And we've also seen increases in VO2 if you just put the tourniquets on and just walk at walking pace on a treadmill or spin at a very low level on a bike. And then when you combine blood flow restriction with about 20 to 40% of a 1 rep max, so a very low load, that's where this thing really starts to shine. And so that's where we start to see hypertrophy and increases in muscle strength. And so as Pierre-Anne mentioned as well, we typically do a 30, 15, 15, 15 with a 30-second rest when you're in this resistance phase down here. You typically don't need to do it as much. It's only about 2 or 3 times a week when you're in this phase. In this acute passive phase, really, we think in what we see in the literature, the more you do it, probably the better. So twice a day and up to 5 days a week during this early phase, if you're able to get the people in there, that's probably where it's the best. But if you can only get them in maybe a couple times a week, that's better than nothing. And so looking at this passive application and kind of some of the evidence for it here. So this was done on healthies, but this is putting people, 3 groups of people in a cast. So one leg, they just couldn't do anything. And so the black bar here is people who were in the cast and just did nothing at all. And so after 2 weeks, they lost about 27% of their quad strength. They lost about 20% plus of their hamstring strength. They lost around 16% of their plantar flexor strength. Then the other group was in that cast, but they did quad sets, hamstring sets, and plantar and calf sets. And so they still lost significant amounts of quad, calf strength. They did, spare the hamstring some if they did isometrics. In the third group here, if they were in that cast and all they did was put the tourniquet on and inflate it for 5 minutes, deflate it for 3 minutes and did that for 5 rounds, they significantly spared the loss of muscle. So during that 2 weeks of mobilization, they only lost about 5% of quad strength. They lost less than 5% of hamstring strength, and only about 8% of plantar flexion strength was lost. And in a clinical model, that's been looked at as well. So this is post-op ACLs. They did that same thing. They put the tourniquet on and inflated it and deflated it for multiple rounds, no exercise, just the tourniquet on. From day 3 post-op ACL to 14 days after. The other control group did nothing. They lost only about 10% of their quad size if they just put that tourniquet on at the end of their session versus about 20% of the quad that was lost in the control group. And the total loss of the thigh, they only lost about 6.7% compared to about 14% in the control group. So the tourniquet did all the work. It didn't create hypertrophy or strength, but it really slowed down that atrophy, the muscle dump that we see during disuse. So we think if you can get your individuals that are injured and just get the tourniquet on and do something like E-stim or isometrics with it, just very, very low level, we can really slow down that anabolic resistance timeline I mentioned earlier. There's a study that came out last year that really tried to see, well, what's going on here that might be slowing this atrophy down. So again, they had the 2 groups where one had the tourniquet inflate and deflate for those multiple rounds, no exercise, but they just let the tourniquet do the work while they were immobilized, and the control group that was just immobilized. And so what they were able to see here, man, this thing's really not moving. What they did as well is they got muscle biopsies so we could look at muscle fiber size. They also looked at what gene expression was going on. So maybe seeing mechanistically what was happening here. And on the muscle biopsy, during that 2-week period, if you put the tourniquet on, it really spared a lot of the quad muscles. So on average, they only lost about 7% of their muscle fiber size compared to about 13% of muscle fiber size that was lost in the control group. So basically cut it in half of how much muscle they lost. And then when they looked at gene expression, they saw that they'd really blunted one of the catabolic pathways. So one of the pathways that tells your body to get rid of muscle, and this is this thing, muscle ring finger 1. So MRF1, when you stop using a muscle, it starts to really go up. And in the control group, you see it goes up, and it goes up by the most by around day 7 to 10. And that's where really telling you to start getting rid of that muscle here. And so, geez, keep it installed out. MRF1 is the atrophy gene. And so if you put the tourniquet on, you basically had a mitigation of MRF1 going up. And so that might be just one of the mechanisms here of why we're seeing, if you get this on early, barely do anything, you're just blocking this gene expression, and it's not telling the body to get rid of the muscle. Once you get to the point where they can do about a 20 to 40% of a 1 rep max, so very low load exercise with BFR, now we're really seeing an increase in muscle protein synthesis. So all of your patients who come in who aren't using their limb, or they're barely using their limb, even if they've reduced walking, their muscle protein synthesis is down. So we as rehab people have a muscle protein synthesis problem, and there's no pill that you can take to make it go up. But when you look at adding blood flow restriction to regular exercise, it looks like it's a pretty potent stimulus for this. And so this was controls who, folks who served as their own controls. So they came in, did leg extensions at 20% of a 1 rep max here without blood flow restriction, and there was no change in muscle protein synthesis at all. If they came back and did those same exercise with blood flow restriction, their muscle protein synthesis went up by 46%. So made that equation more positive. And even in elderly individuals here, average age was 70, doing that same model of a study, they were able to see that their muscle protein synthesis just by doing BFR went up by 56%. And then if you look at it even 24 hours later, so it was up 42% at 3 hours. And then when they looked again at the muscle protein synthesis 24 hours after the intervention, it was up almost 70% higher than baseline. At that point, your patient's home exercise program is to make sure they're getting enough protein in to take advantage of this increase in muscle protein synthesis that you've given them. Also, just kind of want to point out as I wrap up here, we're looking beyond muscle as well. And so one of the potential things that we might be able to help with is bone. And so it's been known for quite a long time that just reducing venous return kind of has a ability to increase bone density. And so if you put here, this is from 1954, experimentally, unilateral treatment with a tourniquet has induced bone overgrowth. And so that blocking of venous return kind of forces the fluid back into the bone, and that acts like a stimulus for what's called interstitial fluid flow and can drive increase in bone density. And this thing is a very powerful driver of bone as well, which is called VEGF. And so if you increase vascular endothelial growth factor, it can really increase positive bone regeneration. And so hypoxia in a limb makes this vascular endothelial growth factor come out. It's been shown in multiple papers that blood flow restriction makes this thing come out. So we have a mechanism that it looks like we can maybe see some changes in bone. And so this study isn't out yet. It was presented at our Orthopedic Sports Medicine Society a couple of years ago. It's in review, so it should come out soon. But if you look at post-op ACL, one group does blood flow restriction, the other group does not. At 12 weeks, the control group had lost 11% of the bone down around their knee. So they're going into this kind of osteopenic state in young, healthy individuals post-op ACL. In the blood flow restriction group, if you're doing those same exercises just with a tourniquet on, they basically lost less than 2% of bone stock. So BFR had this bone preservation state in these individuals. So Dr. Lambert's conclusion here is providing BFR as part of the rehab efforts following ACL surgery appears to help preserve the bone, recover muscle loss, and improve function quicker, according to their research. So this paper should be coming out soon so we can see it. So not only for ACLs, but this is very intriguing for improving bone healing after fracture, or even maybe more important for osteoporosis or sarcopenic elderly females. Another thing that's really caught our attention right now is that doing BFR seems to have an analgesic benefit. It seems to reduce pain in individuals that do it, which is counter to what we know about tourniquets. In the orthopedic world, post-op surgeries, tourniquets seem to cause more pain. They seem to reduce function. In the blood flow restriction world, they seem to reduce pain, and they seem to potentially improve function. And so our first randomized trial we did in the DoD was to make sure that we weren't making people's pain worse by putting tourniquets on them after surgery. So in soldiers who had knee surgery, if we did blood flow restriction for 4 weeks, they had significantly improved pain compared to the control group. And just to point out, in this study, there was no studies that had looked at were there any signs of clotting after you do BFR post-surgery? So we also looked for clots and found no difference or no clots in either the control or the BFR group. Now, many other groups are looking at pain with blood flow restriction along with us in our clinical trials. This is with anterior knee pain from the folks out at Aspetar that did blood flow restriction or the same exercise without blood flow restriction in people with anterior knee pain. And when they reassess their pain on functional tasks like single leg squat, deep single leg squat, step downs, 45 minutes later, the BFR group had significantly less pain. And as they stated here, this allowed the patients to do more things after they did blood flow restriction because they had such less pain in their knee. And they suggest that maybe you should do BFR first in your clinical day to get this analgesic benefit for your patients. Sometimes we've seen it for a short amount of time. Sometimes we've seen it for hours or even days later. They say they still have less pain. We looked at wrist fractures in the military and found that if you did blood flow restriction, we saw no signs of the fracture not healing. And we also saw that people who did BFR after wrist fractures had much, much less pain compared to the control groups. There's two potential mechanisms here. One is there's an opioid release that our body does when we do BFR, or there's a conditioned pain relief, kind of like when you hit your thumb with a hammer, it makes your headache go away type of thing. So our postdoc, Dr. Hughes over in London, tried to see, okay, is there an opioid release with this? So they did heavy exercise, light exercise, BFR at 40% limb occlusion pressure or 80% limb occlusion pressure, all on the leg press. And what they found when they did this is the people that did BFR at the higher pressure had the most pain reduction of all the groups. And when they looked at their blood draws, they had a release of this thing called beta endorphin that was much higher in the BFR groups. And beta endorphin, if you haven't heard of it, it is one of your body's own endogenous opioid that's released by the pituitary gland. So BFR had this ability to get the pituitary gland to release this beta endorphin. Beta endorphin has been known to be released by lactate. So as lactate goes up here on top, once you hit a threshold, then you see that the pituitary gland will start to release this beta endorphin. Jeez. So once you hit this threshold here, the pituitary gland will start to release this beta endorphin. That's been known from exercise. And so when you do blood flow restriction, because you're getting into fast twitch metabolism, you almost always see this large spike in lactate. And so another thing that's released from the pituitary gland is growth hormone. And so as lactate goes up, you'll almost see that the growth hormone curve looks very similar to the lactate curve. That's what we think is going on with this endogenous opioid beta endorphin as well. This study just came out from Dr. Hughes' lab as well that also found that if you did blood flow restriction, not with resistance exercise, but with cycling, you had significantly less pain than the other groups. And you also had an increase in this beta endorphin as well. So pretty much validating those results that BFR can be a way to release this opioid for your patients. So in practice, we use BFR as a way to reduce pain in individuals. For performance in sports, we're doing BFR quite a bit pre-game in nagging injuries to get a window of opportunity to allow the athletes to play with less pain. Just a case study here of showing you how having less pain and less load can really be a powerful stimulus. This is an NFL player. He was 8 months post-op ACL. Everything he was doing was hurting his anterior knee because his quad, he just couldn't get his quad size back. He started with a new team who was doing blood flow restriction, and this is him at week 2 after starting it. And at week 4, my thing's not going to work again. At week 4, basically had got almost all his symmetry back and strength back just by getting that analgesic benefit and also not having to put load through his knee. Lastly here, just one of the things that's really popular in the States is orthobiologics, PRP and stem cell injections and things like that. Dr. Andrews, who's kind of our god of orthopedics here in the US, said, you know, these orthobiologics are the most important revelation in orthopedics since the arthroscope. So we wanted to see, does BFR maybe help with what you want to see from a PRP draw? And so this study just came out recently that we did BFR, drew blood before it and drew blood after to see, do we increase things like your body's stem cell count? Do we increase platelet count? And what we found was if you did BFR versus the control, CD34 is basically one of your body's stem cells, it's a progenitor cell. It was up 72% versus the control group, which is 4.3%. And we made platelet counts go up by 14%. So if you're getting an orthobiologic PRP injection, it might be beneficial to get a blood flow restriction treatment before, or also the things that you're getting those shots for, we're also able to stimulate with blood flow restriction. So maybe we're giving kind of the similar stimulus just by doing BFR as getting these expensive injections. A study came out at the same time from another group we work with that basically showed the exact same thing. BFR made these stem cells significantly proliferate compared to the control groups where they didn't see a significant rise. So blood flow restriction, we think it has a really promising safety profile. Efficacy is something you really want to think about. We're doing limb occlusion pressures on people. We're using a unit that regulates the pressure. The pressure that's being put out from the cuff is the pressure that you're seeing on the unit. We had a study come out of Europe where they used different devices, and only the Delphi system matched up to what the pressure was showing on the system under the cuff. When they were using the other devices, the pressures were kind of all over the place from what they were showing on the machine. Muscle has the most evidence, but there's other parts of muscle which we're really interested in, such as proximal. Can we see changes at the hip and shoulder? And as I mentioned, we're really interested in beyond muscle, bone, tendon. Can we help the vascular system? Can we do this for performance or recovery? And also our big goal is, can we go after the oxidative stress patients, diabetics, cancer, Parkinson's, et cetera. Thank you.
Wow, what a lot to digest. Thank you very much, Johnny. I'll start out with an observation, and that's the fact that you made made a lot of reference to research in the military. And just to point out that a lot of sports medicine research started in the military decades ago. And that's where a lot of information about endurance and training came from before sports medicine came into its own and started doing things on its own. So I found that very, very interesting presentation too. Thank you very much for being so well prepared and giving us so much information. Are there any questions?
Before we go on to questions, Dr. Hanson, may I interject?
Sure, Baron.
Okay. I'm so happy to have you with us, Johnny. And I am pleased to say to our members that Mr. Owens and ORS has graciously, how should I put it now? They have, or they will offer our members a discount for training, and they are offering a $200 US discount to any member that takes their training. So we thank you so much from the bottom of our heart for that offer, and we will make use of that offer. So you'll be seeing some of us for sure at your seminars. Thank you so much.
Sure.
Johnny.
Happy to help. Love to see you guys.
All right, thank you for that, Piran. So we're getting stuff from QualCare and from Johnny Owens, and this has been a good evening indeed. Any questions?
John hasn't signed up.
I'm not seeing the hand.
John Campbell has a question.
All right, John.
Yes, can I be heard?
Yes, we're hearing you.
Right, yeah, give thanks, Mr. Owens. Really nice presentation. Really give thanks. All right, but you mentioned about research being done on Parkinson's disease, which we know is really a progressive neurological disorder. I guess I have an interest in that, having been working with Parkinson's patients and so on. I guess I'm asking you, what is it that you, this is research, but what is it that you would expect in a condition like this? Because the body itself is destroying the neurological systems. What is it that you expect, through this research? What is it that you're looking for?
It was a very, very interesting trial. And so Dr. Annie Bain, she's at Baylor University here in Texas. It was her trial. She had a very interesting question because Parkinson's patients fall into this oxidative stress category. And oxidative stress is basically your body has too many free radicals, and it really starts to play havoc on your vascular system. A lot of the people that have died from COVID are the oxidative stressed out individuals, obese, diabetics, cancer, et cetera, cardiovascular disease. And so Parkinson's patients have very, very bad vascular systems. They have really high homocysteine levels, so they're at really high risk of cardiac events. And they have this condition called the purple hands and purple toes syndrome, where they have such poor vascularity that the ends of their digits start to become purple. So what she wanted to see is there's a lot of interesting research where BFR might help the vascular system. And so she did a 4-week trial on Parkinson's patients where they did BFR at light load or they did heavy load training. And she measured, could BFR make their arterial compliance better? So basically less stiff arteries. And could it also increase angiogenesis where they have better capillary beds in their limbs? And so, she's allowed me to share the results. The paper's not out yet, but it did that. And so over this short window, it improved their arterial system. It reduced their homocysteine levels. It increased angiogenesis in their limbs. And they also got increased strength and hypertrophy as an additional benefit. So in those individuals, and this is the fascinating thing, should we almost look at, if this keeps happening in research, BFR is almost like a 4-week vascular tune-up. So elderly vascular compromised individuals to come in where we do this hypoxic event on them to drive this. And the Nobel Prize in 2019 was given out to 3 physiologists for their work in showing how reduced oxygen levels or hypoxia around cells can really drive this response. So, we're kind of standing on the shoulders of giants here with this. So that was what she was looking at. And I think it's a fantastic trial. I will mention as well, the group that lifted heavy, their vascular compliance.
I think we have lost Johnny.
You lost him?
Back into,
He's back.
He's back.
Sorry.
Yeah, go ahead, Johnny.
No, that was it.
Okay. One question I had was, do you think the use of ultrasound in detecting blood flow and determining what occlusion pressure you should use would be useful? Would this be a good safety net?
Yeah, so that is one way to do it. And so using a Doppler or an ultrasound to look at the vasculature is a one way to do it. So basically, you pump the cuff up until you don't hear the arterial pulse anymore, and that is 100% limb occlusion once that pulse is gone, and then you just release the cuff to a percentage of that. So we typically in the lower extremity train at 60 to 80%. Of that pressure. In the upper extremity, we typically train at about 50% of that. So that is a good way to do it. The only issue with that is it's technically sometimes difficult to do it. You can just roll off the artery and you think it's gone if you're not really trained in it. And it takes some time, so it's a little laborious. And you're only picking up one artery, one superficial artery. To truly occlude, you want to get down to those deep arteries down by the bone. So the Delphi system actually does a circumferential test, and it picks up all the arterial sine waves in the entire limb. So you're getting kind of a deeper LOP, but certainly using a Doppler would be the second way to do it.
The reason I ask is I've had recent elderly patients, and where you're doing pulse ox checks on limbs now routinely for to screen people for COVID.
Mm-hmm.
And I've had at least 2 instances where you got 2 different readings in the upper limbs.
Yeah.
Because one is better perfused than the other. And that says to me, you can't use the same pressure in one upper limb that you use in the other without making sure that you have the correct pressures for each.
You're right. That's called laterality, and that has been found in BFR research as well, that there is a difference in individuals' limbs. The biggest driver of change of pressure is most likely the size of the limb. So the bigger the limb, the higher the pressure. So our pediatric limbs, we're using much lower pressures on them, but that's the biggest driver. But other things play as well. Blood pressure is something that changes it. The width of your cuff is a big change of it as well. But yeah, you're 100% right.
Do we have any other questions? I'm not able to see hands raised, so whoever can see can point the person who has raised their hands. Okay, now I'm seeing it. Diallo, you have a question?
Yes, yes, I do. Yes, Mr. Owens. Yes, thank you again. Really, really good presentation.
Speak up a little louder.
Oh, sorry. All right. Let me come closer. Is this better?
Yeah.
All right. Yes, yes, Mr. Owens. Thank you again. Really, really good presentation. I have maybe 2 questions at least. Can you just repeat what you said? Or all right, put it this way. What I'm understanding is that BFR seems to have effects, like you put it on proximally and the effects are more distal. Is that what you said, or is that correct?
So we know BFR, it seems to really have effects below the cuff, so distal to the cuff.
Right.
We do have some papers that have shown proximal changes, and we just had a shoulder paper come out that found some good changes with muscle size and strength at the shoulder. And so that's our next question. So we do have some hip labral trials. We have several rotator cuff trials where we're trying to see now in clinical populations, can we make change?
Right, because I was going to ask about rotator cuff tears and even, well, it's not really strength, but even say frozen shoulders. I was wondering if there's anything out there on BFR for those kind of conditions, or do you know? Or I guess that's what's going on now?
Yeah, not yet. So we have an operative BFR trial going on in Minnesota. So looking at BFR post rotator cuff surgery, and then we have a non-operative BFR trial. So rotator cuff tears that haven't been to surgery that's being done at Northwestern University in Chicago. One of the things that is the problem with rotator cuff tears is the increase of fatty infiltrate. And so you get a lot of fat in the tendon and the muscle. And it was thought that you just gained more fat. But what the researchers who doing the study at Northwestern showed was that actually the muscle shrunk so much that it just made it look like there was more fat. So the fat was always there, just the hypertrophy went down. And so we had pilot data already that showed on DEXA that we increased the shoulder muscle size. We couldn't say which muscles because it was a DEXA. All we get is just kind of a general, it's bigger. But her hypothesis is, can you increase hypertrophy in these groups so you have less fatty infiltrate? And less fatty infiltrate is typically better outcomes with rotator cuff problems, and especially if they have to go into surgery.
Okay. All right. That's interesting.
Yes, we don't know, but we're hoping, very interested in it.
Right. Yeah. That sounds interesting.
Yeah.
And then another question, maybe it's technical, but very technical somewhat. You mentioned was it the MERF gene, I think you call it?
Morphine, yeah.
Right. So that's an anabolic gene?
Catabolic.
Oh, it's catabolic. Right. Because I've seen where there's been mention of something called mTOR pathway. Is that maybe anabolic?
Anabolic. mTOR that was our main target when we were first looking at this. So mTOR is a basically muscle protein synthesis. Right. And so if you see mTOR go up, you're typically seeing an increase in anabolism and muscle protein synthesis. And so that has been shown in multiple trials with BFR to go up. Those studies I showed you were acute trials where it was one intervention and it's shown it has gone up. One just came out last year where they measured over 6 weeks. And if you did BFR over that 6-week window, it went up about 43%. So that's really good, because if you tell your patients it's going to be down at least 30% while you're in this cam boot or surgery or whatever. And if you do this thing, we're going to drive it potentially up 43%. You've given them hypertrophy.
Right. Potentially. Right. Okay. Yeah. That was going to be my
question. As long as they're eating their, taking in their protein and have a good diet.
Right. Okay. There you
go. Okay. I have 2 other questions, Johnny. You showed a series of slides of muscle loss over a period of time up to 14 days.
Mm-hmm.
what happens after 14 days? Is there still efficacy in using BFR?
There is, you know, and like that case I showed of the football player, you know, he was 8 months out. And
Okay.
so we like to start it early. And then you know, just don't have time. I love the chronic cases. You know, I always tell people, if you're just starting this and maybe you want to get your surgeons involved, ask them to give you one of their chronic cases that just isn't getting better. Because they're usually like, I'll do whatever. They're not worried about post-surgical, you know, complications or anything. And those people, it can really turn them around pretty quickly. So I like those. Dr. Noyes, who's a pretty big orthopedic surgeon here in the States, they just did a study and took his knee patients who were plateaued and weren't making changes. They called it severe quad deficits. And they were all on average about 8 months out. If they did 9 sessions of BFR, I'm trying to remember the number here. They increased, I think, by 20% strength in, I think, 60% of them. If they did 18 sessions, almost all of them significantly increased their strength. So, you know, it might take a little bit more time, but it still showed in these chronic cases that they were able to turn it around.
Okay. The second question I had was one that was of practical importance. Sanitization of bands between patients now in our current context.
Yeah. So we use a limb protection sleeve. So we have a sleeve that goes under the cuffs, and it's good for sanitation because you can just, the patient can keep it, it's their own, or you just throw it away and use a new one each time. You can use stockinette or something like that you would put under it. What they've found in the surgical literature is that if you use no protection under the cuff, you have a 5 times higher blister risk. So you can actually blister the patient if you don't put something under there. So we always recommend putting something under there. If you use 2 layers of protection, it took the blister risk down to 0. If you use 1 layer of protection, they still had a 3 times higher blister risk. So when you use 2 layers, actually the friction is caught between the 2 pieces of material. So we have these sleeves that are double layered, or you just use 2 layers of stockinette. During the pandemic, Delphi actually, they have tearaway ones now too that you can put on. We use it a lot in the pro leagues where they can just put it on and you tear it away and throw it away when you're done, almost like the tearaway shorts.
Okay. All right. Any further questions?
One last one. So, Johnny, in terms of range of motion, any huge improvement there? I know muscle strength goes up, but say when you have your knees per se, chronic, and you have plateaued in terms of getting range of motion increase.
So, Dr. Hughes and Dr. Patterson over in London, they did an NIH, so their National Healthcare System ACL trial in the United Kingdom. And the BFR group compared to lifting heavy had improved range of motion significantly compared to the lifting heavy group. They had less effusion. They had better functional scores, and they had basically both of them had equal strength improvements and hypertrophy improvements because the other group was lifting heavy. But the BFR group consistently had those other improvements, and it was probably just from not pissing the joint off. You know, you're doing a low load. He started it fairly early. There is a trial that's, I think it's almost wrapped up in Houston at Memorial Hermann Houston. And kind of they've teased that it looks like the BFR group has had significantly better range of motion as well. So in those postoperative groups, yes, it looks like maybe that low load is a way to do it, or maybe there's another mechanism we just don't know. What we're interested in is, can there be a reduction of fibrosis, you know, like maybe a frozen shoulder or something like that. The pathway that creates scarring in your body is called TGF-beta. I'm sorry. Yeah, TGF-beta. Am I saying that right? Anyways, it's part of the myostatin pathway. Sorry, I'm blanking out. So this pathway comes in, and myostatin lives in your muscle. And whenever you injure yourself, myostatin gets released. And then myostatin calls the fibroblasts in, and the fibroblasts come in and they start to scar down the muscle. And there's a couple of papers that have shown that if you do BFR, it actually makes myostatin go down. And so that could also be, is there a way that we can reduce those myostatin levels and address scar? There's a trial at the University of Kentucky that's actually looking for that. They're the folks that did the muscle biopsies post-op ACL, and they're going to measure and do BFR and see if they can take that myostatin level down. And on biopsy, is there less scarring? So it's interesting. I mean, we've even discussed in the military looking at this with burn patients. And not only burn patients have very bad bone density. I mean, it's almost see-through if you have severe burns, and they have a ton of scarring. So, you know, if we can give them strength and hypertrophy and tackle the bone and scar, that's just huge. You know, it might be pie in the sky, but we can hope.
What I've noticed is that the just humongous increase in research since the 2000s.
It's crazy.
Before it was like limited, and now there's so many papers out there.
Yeah.
You know?
Jeremy Linecky, who's a big BFR researcher here in the States, he and I just did a talk together, and he had a slide and he just showed the amount of publications is just, it's basically like a hockey stick right now. It's crazy. Yeah. Which is good.
Diallo, your hand is raised still, Diallo?
No, I had one last question.
Yeah.
Right. Yes, Mr.
The
Owens,
last one.
Right. Okay, no problem. You had, well, obviously BFR from how you show BFR is really a clinical, I guess a clinical intervention. And of course you mentioned it in terms of scope of practice for PTs and so on. But then I remember, but even before I heard of BFR years ago, I heard of bodybuilders using something called occlusion training, which I guess seems to be the same thing. And I saw where you show those straps on like Amazon, guys just occluding themselves and doing that. So I'm wondering, BFR, is it always something that requires a clinical scope of practice, or is there a use for it within the strength and conditioning realm? Do coaches use it on the athletes as just a training thing, or is it only a clinical thing?
So we are doing it quite a bit for performance and strength, especially with the teams right now. So we're still using, you know, like an FDA device and train people that do it. Now, you can do anything in the world to yourself. If you want to wrap a cuff around your neck, you can do that. I wouldn't recommend it, but you can do whatever you want to yourself. And so that's perfectly fine. The problem is once you decide to put something on another individual as a clinician, you've opened up the whole new can of worms. And so if something did happen, you just got to make sure that your liability is there. I will say, if you see like a big meathead in the gym that's lifting heavy weight and they got straps on, you can tell them they're probably wasting their time. Blood flow restriction is a low load game. When you lift heavy weight, your muscle contraction is so strong that you're basically occluding the vessels already. And so all you're doing is throwing an extra cuff on an already occluded limb. That's why BFR and lifting heavy are very similar. They both have this hypoxic state. So there was a study out of University of Michigan looking at lifting heavy post-op ACL at 12 weeks out or lifting heavy with BFR, no difference. It didn't change anything.
Okay, that's interesting. Yeah, that's actually good to know. Okay.
There's really cool applications right now for performance. And I would love to get some of y'all's awesome sprinters and start looking at this with it. Because, you know, this thing called ischemic preconditioning, you just lay there and you have the tourniquets go on and off and on and off before you do an event. That's shown in some pretty elite individuals to really move the needle on things like their sprinting and their swimming trials. And so that is a huge burgeoning world right now. And then there's another thing where we're looking at putting it on right after you play a game or something. And there's been some studies that have looked directly at blood draw that you have less muscle damage and a faster return of strength. And so I don't know if you saw during the Olympics, BFR was kind of all over the place. They called it the cupping of which like made my eyes roll. I don't want anything to be compared to cupping when we're looking at it.
Okay.
All right.
Thank you.
We want to say thank you very much, Johnny. Very, very, very interesting presentation. We have just one other person on the agenda, and it will be a review by Dr. Jodianne Simpson, our very own Jodianne Simpson. I'll ask Dominique to introduce Jodianne now.
All right. Good afternoon, everyone. Can you all hear me?
Yes.
Awesome. So for our next speaker, we will be listening to a presentation on patellofemoral pain and how blood flow restriction can help in its rehabilitation. So as professionals in sports medicine and sports rehabilitation, it's clear that this practice has gained some popularity over the years. So today we hope to gain some additional knowledge on its effects, the advantages, disadvantages, so that we can make some evidence-based decisions in its use, right? So our speaker has a budding career in sports physical therapy. She has provided coverage for several sports teams, including Jamaica's women rugby and basketball teams. Her experience has also brought her across the Caribbean to Anguilla, where she covered the national football team, and Trinidad and Tobago's Central Football Club. She received her Bachelor's of Physical Therapy from the University of the West Indies and her doctorate in physical therapy from Nova Southeastern University. She has certifications in several areas of physical therapy, including a level 2 immediate care in rugby, lymphedema and wound care, as well as functional integrated dry needling. If you have ever met her speaker in person, then you know she has a smile that illuminates any room. So ladies and gentlemen, please welcome to your screens, Dr. Jodianne Simpson.
Welcome, Jodianne.
Thank you so much, Dominic, for that introduction. Thank you to the Central Chapter of the Jamaica Sports Medicine Association for allowing me to do this presentation. And I also want to thank the two presenters that came before me. They did an amazing job and they just made my work and presentation a little bit easier. The beauty about being the final presenter. So I want to thank them for that. So all I am going to do in my presentation now is just to, put everything together, conclude everything that the previous presenters have said. And I am going to start now. So let me share my screen. All right, so can everyone see screen? All right, so the topic is patellofemoral pain. Are we under training and how blood flow restriction can help? So we'll do an overview of what the presentation is about. We'll have a summary of patellofemoral pain syndrome, the causes, some common interventions that we use in physical therapy, blood flow restriction, how blood flow restriction can help, and then we'll move on to our concluding statements. All right, so patellofemoral pain syndrome. This is a broad topic or a broad term that is used to describe pain arising from the patellofemoral joint and or its surrounding structures. And we usually have pain with squatting, running, ascending and descending stairs, prolonged bending of the knee joints. And it affects 1 in 14 adolescents, 1 in 5 of the general population. And females are more likely to be affected than males. So moving on to just a little anatomy here. Now the knee joint is made up of 2 main joints, the patellofemoral joint as well as the tibiofemoral joint. And we have the patella being the capsule of the joints here behind the patella that assists with the fluidity of the patella to move over the patellofemoral groove. Within the structure, there are also bursas. And what happens within the patellofemoral pain syndrome is that these structures usually are the ones to get inflamed and causes pain. pain during the activities that I mentioned before. All right. So now let's look at some causes of the patellofemoral pain syndrome. Now, it can be as a result of trauma. It can be as a result of overuse or overloading of the patellofemoral joints, as a result of anatomical or biomechanical abnormalities, where the patella might not sit in the patellar groove comfortably. So we will have tilts or lateral shifts that may cause some issues as it relates to patellofemoral pain. We can also have muscular weakness or imbalances. So the VMO, one of the muscles surrounding the patellofemoral joint, is sometimes found to be weaker than the vastus lateralis, which is the other muscle on the outside of the joint. And that can result in dysfunction of the patella, or vice versa. The tilting can result in dysfunction of the muscles, resulting in them being imbalanced. Now, some common interventions that we use as in treating patellofemoral pain in physical therapy. We have pain management, strengthening of the quadriceps muscles and the hip muscles, manual therapy, taping, and orthotics. Now, of all these interventions, strengthening of the hip muscles and the quadricep muscles, daily taping, and orthotics were necessary if the issues are arising from the foot, are the most supported by evidence interventions, that we use. So in terms of strengthening, we will have some guidelines that we use from ACSM that it is required for us to be strengthening at 60 to 70% of the maximum load a person can lift. Or if we need to be, for the muscle to be hypertrophic, then we go to 70 to 85% of the maximum load a person can lift. Now the question is, are we under training persons with this condition because they can't do certain exercises due to pain? And this study that I'm about to look on, did some research on that effect. So this article entitled Quadriceps Strengthening with and Without Blood Flow Restriction in the Treatment of Patellofemoral Pain. It was a double-blind randomized trial done in 2017, and the authors are there. 69 participants were in the study, and their inclusion criteria was if the persons were 18 to 40 years of age, if they had atraumatic onset of anterior knee pain for greater than 8 weeks, if they had pain with any two activities such as running, jumping, squatting, kneeling, going up and down stairs, or prolonged sitting, or if they had pain with any two patellar compressions, whether it be palpation of the anterior knee structures or resisted isometrics in sitting for knee extension. The participants were excluded, however, if they had already started doing quadriceps strengthening, if they had a history of patellar subluxation or dislocation, any other sources of anterior knee pain. For example, if they thought it was a patellar tendinopathy, they were excluded from the study. If they had previous knee surgery, they were also excluded. Or if they had any cardiovascular conditions or any unexplained chest pain with exercise, or if they were pregnant. Now, the article placed these 69 participants randomly into two groups. And these two groups were the high intensity standard quadriceps strengthening and the low intensity quadriceps strengthening group with blood flow restriction. Now, the study lasted for 8 weeks with a follow-up at 6 months. And during this 8-week period, they were doing training sessions or exercising 3 days a week for the 8 weeks. Now, for the high intensity standard quadriceps strengthening group, they were exercising at 70% of their 1 RM. However, if they had any pain on the VAS scale above 2, then they would reduce the load by 20%. In the low intensity quadriceps strengthening group with blood flow restriction, they also did exercises 3 days per week for 8 weeks, but exercising at 30% of the 1 RM. Now, the exercise routines were the same, meaning, so both groups did cycling for 5 minutes as a warm-up at light intensity, and both groups did a leg press as well as a leg extension. The leg press, 0 to 60%, 0 to 60 degrees, of knee flexion was used, and the leg extension, 90 degrees to 45 degrees of knee flexion was used. Now, in the BFR group, as mentioned before, 30% of the 1 RM was used with the cuff inflated, and they originally did 1 set of 30 reps until volitional fatigue. And then they did 3 sets of 15 reps of each. So 3 sets of 15 reps of the leg press, as well as 3 sets of 15 reps of the leg extension. And then they had 30 seconds rest between each set. The cuff was removed only after the exercises were completed. While in the standard quadriceps strengthening group, they were exercising at 70% of the 1 RM with a placebo BFR cuff. Well, it was an elastic cuff that had enough room to place 2 fingers within the cuff. And they did 3 sets of 7 to 10 repetitions. Now, I think this slide, I don't need to go over it, but just for memory's sake, blood flow restriction training is when they use a pneumatic cuff proximal to the target muscle during strengthening exercises, and the cuff restricts the arterial blood flow and the venous return, causing greater rate of muscle fatigue. So how did they measure the arterial occlusion pressure? Was that they placed the cuff on the quadriceps muscle, on the proximal quadriceps muscle thigh, and then they used the Doppler ultrasound, and they measured the pedal pulse. So they pumped the cuff up until they could no longer hear the pedal pulse, and then when they released it, they recorded where they started hearing the pulse from, right? And then they performed the BFR treatments at 60% of the pressure that they had. Now, for the article, oh, we went through this before. The outcome measures that were used were pain. So the VAS scale they used with 1 being the worst pain in the past week, and if they had pain with their activities of daily living, which included squatting, descending stairs, and 30 minutes of sitting. So they were asked if they had pain with these activities, and they recorded it on the scale. They also, for function, they used Kujala's Patellofemoral score, and for quadriceps strength, they measured knee extensor torque with a Humac norm dynamometer. And the force of knee extension was measured from 105 degrees of flexion to 60 degrees of flexion. And they did 3 sets of 5-second trials. And they were asked to report if they had pain during the test, or if the pain had prevented them from pushing any further. The quadriceps size was measured using ultrasound, real-time ultrasound. So they measured the belly of each muscle, and then the sum they estimated the quadriceps size for each muscle. They totaled it, and then that's when they got the quadriceps size. Now, the results of the study showed that they had improvements in quadriceps. The high intensity standard quadriceps strengthening group had improvements in the quadriceps thickness in 8 weeks, but there was no improvement in the thickness of the blood flow restriction group. However, with the blood flow restriction group, there was a greater reduction in pain with ADLs 8 weeks after, even though these benefits did not carry over into the 6-month period. Also, there was greater improvement in the knee extensor torque in the blood flow restriction group. There was no significant change in the worst pain or the function outcome measure, right? So which means that both of them had improvements, but none was significantly better than the other. Give me a second. Let's see. All right. So, in discussing the limitations of the study, participants in the blood flow restriction group had significantly more pain with ADLs at baseline than those in the standard quadriceps group. Now, this resulted in this limitation could give us a difference because of the difference in the baseline measures of the BFR group versus the standard quadriceps strengthening group. Then the fact that the pain reduced is not directly relating to the activity, but it could have been because of the intervention and not because of the difference. So they're saying that the pain would have decreased anyway, and maybe that's why it was decreased more in the BFR group than the standard quadriceps strengthening group. All right, so the conclusions of this study suggest that BFR has a similar, has a similar effect to standard quadriceps strengthening in reducing worse pain and pain related to function, and especially in patients who cannot tolerate standard quadriceps strengthening. So based on the fact that there were improvements in pain reduction as well as improvements in the muscle knee extension torque, then it shows that there is room for using BFR in strengthening the quadriceps in patients who are unable to do the exercises, do the regular strength training exercises at 70% of their 1 RM in order to get the benefits of muscle strengthening, in order to decrease the amount of pain or that they have by having the patellofemoral pain syndrome, right? So this just shows the applicability, of using the BFR treatment within this condition in our clinical setting. All right, and these are my references. So nice and short, and I welcome any questions that you may have. Thank you.
All right, thank you very much, Julian. Very good presentation and a nice way to bring everything together. Are there any questions? Julian, could you stop sharing so that I can stop sharing your Yeah, thank you. Any questions? Can I see the hands, please? All right. I am not getting any questions. So without further ado, we will close by asking Ashley.
Sorry, David.
Yeah.
I was asking, what's the cost of the course that Johnny Owens is giving us a $200 discount off, please?
If Johnny is available, he can answer. Or Piran, do you have the details of that?
Yes, please.
It's $650.
Okay.
Okay, so we pay $450. Thank you very much. Very much.
And these Johnny
members will be verified.
Say that again.
Members will verify members.
Right. Right. And the plan, I suppose, would be to work out the details with Johnny and then disseminate the information to the rest of the membership.
Correct.
Correct. Okay. All right. So, Ashley, we're going to ask you to move the vote of thanks to these three excellent presenters. And I leave the floor to you now.
Hi, everyone. It's my pleasure to bring the vote of thanks today on behalf of the Central Chapter of the JASM. This event wouldn't be possible without the help of these key persons whom I would like to highlight briefly. To those who joined us via Zoom and YouTube, thank you for being here. We're glad that we can facilitate learning and sharing within the JASM community and beyond. Immense gratitude as well to our moderator and president of the Central Chapter, Dr. Hansen, who deftly guided this afternoon's activities. Special recognition as well to our sponsor, Qualcare. Thank you for partnering with us on this event and sharing with us about your immune support products. We also want to extend gratitude to Dr. Ratri and the members of the JASM Education Committee who offered technical support for today's proceedings. And of course, we have to say a big thank you to our speakers for accepting the invitation to share with us today. Mrs. Brown, you got the ball rolling with your introductory presentation. It was certainly eye-opening, and I know that many of us will be putting this knowledge into action very soon. Mr. Owens, thank you for your comprehensive presentation. We appreciated all the useful examples and research that you provided and how you highlighted the potential muscle protein synthesis challenge that rehab professionals may face. Again, thank you for your discount offer, and we'll certainly be making use of it. The case study by Dr. Simpson was the icing on the cake and certainly helped put things into perspective. Additionally, we want to recognize the JASM for providing this platform and framework which promotes continued education within our community. And finally, an event like this can't happen overnight, so we must acknowledge the work done by the members of the Central Chapter, led by Dr. Hansen, in putting it together. So again, thanks to everyone for logging on today, and we hope to see you at the next Keeping Pace seminar.
Thank you very much, Ashley. A job well done. And I personally would like to say thank you to Piran, who was the one who brought this topic to the fore for discussion. And I'm glad we agreed to explore it some more. It certainly has been interesting and an evening well spent. Thanks everyone for attending, and thank you, Johnny Owens, for making yourself available. Good evening.
We're asking all members of Central to stay online for a brief 2 minutes along with Mr. Owens. Thank you.
All right, I'll just end my contribution and stop the recording. Well, Joan, you can stop the recording.
Thanks, everyone. Terry needs to stop the recording.
Oh, okay.
Terry.
Okay.
Thank you.
Yes.
Okay, folks, thanks, David. Thanks, Central Branch. Great job. And
Thank you.
We'll keep in touch. See you next week at our DGM.
All right. Thanks very much, Joan.
Thanks much.
Thanks, David. Good evening, everyone.
Good evening.
Leaving now. Bye.
All right.
Bye.
All right, thank
Central
you.
Life. And Dr. Jones. There, we're on.
Yes, go ahead, Darren.
Oh, we just wanted to do a photo op.
Okay.
Oh, I thought refreshers would be served or something.
Yeah, hello, what you doing
Yeah,
there?
hello. Yeah, what you doing there?
I was ready for the
What the hell
refreshers.
are Audrey doing there?
I'm trying to go and it won't let me. Didn't want to invade the meeting.
I think you need to stay.
Photo bombing. Joan, that's Joan. Audrey. All right. Even if you don't have on your shirt, you can open your videos.
Guys, were you hearing me or did I cut off at the end?
No,
you heard everything clearly. Quite
You did a good
nicely,
job.
actually. Yes.
Yeah.
Okay, okay. I thought I went out.
We can always ask Johnny if he's impressed.
How was it for you, Johnny? What do you think? What did you, yeah. Can't hear you. Yes, we're hearing you now.
Oh, it was good. I'm sorry, I couldn't hear what you said.
Oh, I was saying, what did you think of our webinar?
Oh, I thought it was great. Super professional. It's awesome, especially for a Sunday. You guys have more stamina than I do.
Nice to have you.
Thanks for having me.
Yes. So you have been to Jamaica? Yes.
When I was in college, a long time ago.
Spring break.
Yeah.
Was it?
Yeah. I had just torn my ACL and I went there a couple months later. So, yeah, just laid on the beach.
Where is headquarters for you?
San Antonio.
San Antonio. That's Texas, right?
Yeah, Texas.
Denver or Texas?
Texas.
Texas. San Antonio.
Okay. Yes, guys. So the closest course next year is in Florida, Oakland Park, for those of you familiar with Fort Lauderdale. So we'll definitely be trying to make a trip, or some of us will try to be there. Please remember, guys, that there is scholarship, stipend available through JSM. So please.
How long is the course? How long is the course?
How long is it?
It's
weekend?
8.5 hours, one day.
Okay.
On a Saturday. And then there's too much information to take in really in one day. So we have a private group that everyone.
Terry, supposed to be doing.
I'm sorry.
Go ahead.
No, just after the course, we try and do a lot of things to support you. So we have a private group because you're going to run